So when you do a study like this, you want to first show results after more or less appropriate time. You cannot wait for 10 years before you report the results. That is the reason why we first focus on progression-free survival, because we can report on progression-free survival after 4 or 5 years observation period, 5 years observation. However, it's still debated if the progression-free survival is the best and most relevant endpoint. So therefore there's a big need to show also a long-term follow-up to report on the overall survival. With the question, is there any late complication potential? Are there any late infections? Is the death rate late on surprisingly high or low? So what in the end counts for the patient is the overall survival. And when you would report overall survival after 4 years, probably the results are not mature, it's too short. Therefore, it's very important to have a follow-up. To reassure, to confirm our observations at 7 years, to see if something has changed between the last 3 years in terms of overall survival and in terms of secondary malignancies, the late complications. And also, when we asked our study sites twice in the last 3 years, we really got some confirmation and some good quality of data, because we repeatedly asked the same question. And we always ask the question, is the patient alive or has he died? If he has died, when was it and why? Second question, we asked the doctors, was there any need for second-line treatment? And again, that can be different from 7 years to 10 years follow-up. And the third question was secondary malignancies. And we always ask exactly these questions. I would say that in StiL-NHL1 we see the real patient population of the real world. And the reason for that is because we have more than 100 participating study sites. In the NHL1 exactly it was 81 study sites. Today we have 130 in the StiL group. And we have all type of doctors who participate in the clinical study in Germany, like private practitioners, like community-based hospitals and academic-based hospitals. That means that we probably have a picture of the real world, because everybody is participating, and within 80 centers you do not have a positive selected patient population. Everybody who comes in your office and fulfill inclusion-exclusion criteria is in that study. Also, the median age reflects what is expected. The median age was 62 years. That is exactly what you expect as a median age for this kind of disease. Very often you see that a study was done in a patient population with the age of 55, and that probably reflects a positive selected patient population. So I think StiL-NHL1 represents the real world. For the patients is of course much improvement of the quality of life. If they have an ongoing remission, they feel safe and they do not need to go back to the hospital for a second chemotherapy. And therefore they can continue their normal daily life much longer than it would be interrupted by a second chemotherapy, by an event of a relapse. So it means a lot. And we have 77 patients in the BR group who were treated with a second-line treatment, compared to 109 in the CHOP-R group. So I think it's a better control of the disease with the one group against the other, and that means a lot. Also, of course, in the end for the community and for the doctors. The doctors feel very much reassured that they recommend a very good treatment with a long-term effect to control the disease. And the community is saving costs when they do not need to pay for a second-line treatment in the lifetime of a patient, or in this time where we had the observation of the study. So also from a pharmacoeconomical perspective, it is very positive that you need less second-line treatments in the end. I don't know any study who showed a difference in overall survival in this low-grade lymphoma, because second-line, third-line treatment, fourth-line treatment has a lot of influence on the long-term outcome and on the long-term overall survival. You should have done theoretically a comparison of BR against CHOP-R and should have allowed not any patient relapsing after CHOP-R to use BR, which is not ethical and which is not possible. And only then you could detect if the one or the other treatment translate into a survival difference. So 50% of the patients after CHOP-R were treated with bendamustine rituximab, and of course this is a crossover of the study groups and of the treatments. Therefore that influences, of course, a potential difference which you can maybe detect in the overall survival. Still, in the end, the overall survival was not statistically significant different, but it was numerically a little bit better for BR versus CHOP-R. Very well-known factors for prognosis. We just have looked if that is also true in our patient population, and it would be a surprise if it would not be like this. So we confirmed what we expected. FLIPI is a clear prognostic factor, and also the LDH. Interestingly, the LDH really was in our hands a strong predictor for survival. A patient who started with a normal LDH really had a much longer survival than the patient who had initially, when they started the study, a high LDH. And then we looked in these subgroups for the comparison of BR against CHOP-R, and that was one of my conclusions on my last slide, that I found a statistically significant overall survival benefit for the patients who have initially a normal LDH. And why was it important for me to say? Because I feel this is probably the patient group with a real and correct diagnosed low-grade lymphoma disease. When the patient would have a high LDH, probably you have some patient in this group with an underdiagnosed or misdiagnosed aggressive type of lymphoma. So I wanted to say, if you really have a classical and correct diagnosed low-grade lymphoma, the best treatment for sure is bendamustine rituximab, because in this exploratory subgroup analysis even there was an overall survival benefit in favor of bendamustine rituximab. So in our study, the comparator was CHOP rituximab. I think both treatments have their potential to have acute toxicity, which is very important. So you have to handle the acute toxicity. In the long-term effect, I don't see too much complications. When you have an ongoing remission, then you are in a more healthier performance status, and you probably don't see too much late complications. So our biggest concern was the incidence of secondary malignancies, which we have reported here, and I do not see any incidence of late infections, because when a patient is in an ongoing response, he has a good performance status and the risk for infection is smaller. And I have to make also this one comment. Our study, which I have reported here, just compared 6 cycles of BR against 6 cycles of CHOP-R. So no maintenance was given.